So, good morning, good afternoon, all of you. I hope I'm audible and visible. Please give me a thumbs up if my audio video is clear to you and if you can hear me properly. Please give me a thumbs up if my audio video is clear. So, welcome all of you in the next session of Let's Crack NEET PG. So, everybody knows that the pattern of NEET PG has changed a lot. And keeping that in the mind, we are here to bring, or this new session has been created so that we can update you with the upcoming or the new pattern questions which can be asked in your upcoming NEET PG entrance examination. Please remember, instead of 300 questions, now you will get only 200 questions. And instead of subject wise questions, we will get the system wise questions now. And that is why we are expecting more and more of integrated questions. Keeping that in the mind, this whole month I will be revising the integrated questions to everyone. So please follow every day at 12:05 p.m. every day. Follow me on the YouTube channel of Unacademy, that is Let's Crack NEET PG. Now I am Dr. Cheshta Agarwal, your NEET PG educator and the top educator on Unacademy. And you can ask me anything related to your preparation for NEET PG entrance examination. Feel free to ask anything. Now, why to choose Unacademy? Please remember, Unacademy is the best online platform for the preparation of NEET PG or say any other entrance examination for PG. Why? Because it gives you the benefit of live interactive session where you can ask anything, any query related to your topic immediately at the time of a live class. No other online application give you this benefit, especially if we are talking about the pre-PG preparation. The next is we have two modules, one is free module and one is paid module. On free module, we have something called as special live classes. Every day, all the educators take free classes which are live interactive sessions. Second is you have many quizzes, test series which is either daily, weekly or even fortnightly. And there is another very interesting session, that is the combat sessions. Now these combat sessions are the sort of a scholarship test because the top students will get amazing prizes in the form of Unacademy subscriptions, or they can even get the Amazon vouchers. Now what you all have to do, you just need to unlock these things, and whenever you download the Unacademy learning app, they will ask for an invite code. You can use the invite code CHESTA10. On using this code CHESTA10, you can have access to any of the classes on Unacademy, whether it is free special classes, whether it is quizzes or combat. So requesting everyone to please please download the Unacademy learning app. Give a try to special classes first, and if you like it, then you can go ahead with the plus courses. Now right now we have many batch courses going on, that is we have a system wise clinical rapid revision batch courses, we have a target next 2020, we have a last mile NEET PG batch, we have a focus batch, operation batch and target batch. There are many batch courses which are going on. I request you to please get yourself enrolled into any of these batch courses. We have many test series which are coming on, that is NEET PG, FMGE, NEET PG 2020, INICT, Grant Test series as well as scholarship test. All of them are absolutely free. So at least if you don't want to buy a subscription now, you can access to these free things simply by using the invite code, and that is CHESTA10. Use my invite code CHESTA10. Okay, now there are two types. If you want to get yourself enrolled into the batch course, then you need a plus subscription. We have two types. One is Iconic, which gives you an access to Unacademy as well as Prep Ladder, and this is best if you are planning for next 2022 entrance examination. The 1 year subscription fees is around 55,000 rupees, but if you use my referral code CHESTA10, it becomes 49,500. If you are in pre-final, I will suggest either go for an 18 months or a 24-month subscription because the per month cost becomes very less. So the 24 months or 2-year subscription will become 69,300 rupees, I think, which is very affordable if you compare it with that of the offline coachings. So please get yourself enrolled into any of these courses. Now if you are planning for the NEET PG entrance examination, which is after 1 month, for NEET PG entrance examination, I will request you to go for a 1 month subscription, which is 5,000 rupees. And if you use the referral code CHESTA10, you will get the same thing in 4,500 rupees. So we are done with all the information, starting with the first question of the today's session. Please answer this question. Everyone, I request you to answer this question. Please answer the question. A 5-year-old boy presents with sudden onset of diffuse purpuric and petechial skin lesions without fever at the pediatric department. The following days, he develops diffuse abdominal pain with bloody stool. He also complains of scrotal pain, joint pain, and his previous medical history was unrevealing. What is the diagnosis? I request everyone to please answer this question. I hope you can see the clinical picture carefully. I think there is some issue. Just a second. I'm not able to see anybody's answer. Okay, is it visible now? Yes, very well done, everyone. So please remember, this is a very important integrated question. What does the question say is that a 5-year-old boy presents with sudden onset of purpuric lesions. Now he has abdominal pain as well as joint pain. So whenever you get a classical triad, whenever you have a triad of abdominal pain, whenever you have a triad of abdominal pain, joint pain, as well as the purpuric eruptions, this is a classical triad of Henoch, Schönlein, purpura. So the correct answer becomes option number 1, that is Henoch, Schönlein, purpura. I hope this question is easy for everyone, that a young boy presents with palpable purpura associated abdominal pain, then this is HSP. Now can anybody tell me, if you do the biopsy of these lesions, what will you see? Is it an immune complex or a non-immune complex mediated disease? Very well done. Please remember, you will see presence of IgA deposits. You will see presence of IgA deposits in these individuals because it is an immune complex mediated vasculitis. So we are done with the first question. Let's move to the second question. Everyone answer this question. I'll just move it a little bit over the left so that you will get an idea. Please answer this question. A 23-year-old female patient presented at a 26-week gestation with a 1-month history of generalized body rash that was worsening. The rash started from the armpit and neck and later spread to the trunk and the rest of the body. She also reported history of fever chills for 5 days and she had no personal and family history of any other dermatosis. Physical examination showed erythematous scaly figurate lesions with pustules on the periphery, and a biopsy revealed spongiform pustules of Kogos with neutrophils forming intraepidermal and multilocular microphases. Can anybody answer this question? A very easy and a simple question. 23-year-old female, so it is a pregnant female which presented with these lesions. Giving you 30 seconds to solve. Okay, very nice. The correct answer is impetigo herpetiformis. Now, why it is impetigo herpetiformis? First of all, the first and the very important clue which is given is the biopsy revealed spongiform pustules of Kogos. What is this spongiform pustules of Kogos? This is nothing but this is the collection of neutrophils. This is collection of neutrophils in stratum spinosum in the patients of psoriasis. So that is the first clue towards the diagnosis. The next clue which you should all know with respect to this is the pregnant patient have developed this. Okay, 26 week of gestation along with the history of fever and chills. So this is a form of acute generalized pustular psoriasis. acute generalized pustular psoriasis, which is called as impetigo herpetiformis. Can you tell me what is the diagnosis for this condition? Anyone? How to diagnose this condition? Anyone? How to diagnose this condition? Yes, very nice. Or how to treat this condition? For treating this condition, you have to give steroids. Please remember, you have to give steroids, oral steroids for treating this condition, because it is considered to be a life-threatening condition both for the baby as well as the mother. So you need to treat them by giving oral steroids. If this is clear, please give me a thumbs up so that I can go to the next question straight away. Rahul, I hope this is clear. Now another question is here on your computer screen. A 42-year-old male presented with a history of painful, gradually enlarged subcutaneous nodule which have restricted the movements. In dermatological examination in both the elbows were included. There are nodules of the size 5 mm to 2 mm. You have been given some of the findings of the lipid profile. You have to tell me what is the diagnosis. So Kennedy, what is the confusion? What do you want me to repeat? Okay, I will tell you the answer in some time, Kennedy. For now, please solve the question given. I will explain the impetigo herpetiformis again, but before that, I want you to solve this question. So what is this? A 42-year-old male presented with painful and gradually enlarged subcutaneous nodule with restricted joint movement. The dermatological examination. So please try to answer them. Very nice. So this is a classical example of tendon xanthoma. Very nice. What is tendon xanthoma? It is a classical feature of type 2A hyperlipoproteinemia. It is a classical feature of type 2A hyperlipoproteinemia, that is tendon xanthoma. Please remember this point. Very, very important. Okay. Now what happens in the type 2A hyperlipoproteinemias? There is abnormal LDL receptors. When LDL receptors are abnormal, the LDL is not getting absorbed, and because of this, the circulating levels of LDL will increase, and LDL is rich in cholesterol, so you will have more and more cholesterol circulating in the abdomen or circulating in the blood vessels. This will start getting deposited over the tendon, and that is called as tendon xanthoma. Okay, so I think this question is clear. Now Kennedy wants me to explain this question again. Please remember, Kennedy, whenever you see the spongiform pustules of Kogos in a pregnant patient with associated constitutional symptoms, it means that you are dealing with impetigo herpetiformis, which is also called as acute generalized pustular psoriasis. And in these individuals, you have to give oral steroid as a treatment of choice, because otherwise this can be a life-threatening condition for both the adults as well as the newborn. Please answer the next question given. And Kennedy, if this is clear, I want a thumbs up from you. If that is clear, please give me a thumbs up. If you like these questions, then please you can subscribe to Unacademy. Use the referral code Dr. Cheshta YT. Dr. Cheshta YouTube. You can access using this Dr. Cheshta YouTube. A 1-year-old boy referred to skin department of General Hospital with skin lesions as shown. Up to the age of 6 months, the child was normal. After that, he developed alopecia rash over the face, knee, elbow and perineal region. There was history of fever on and off during the past year. What is the diagnosis? Anybody can answer this question? Rahul, Kennedy. 1-year-old boy was referred to skin department of General Hospital with the skin lesions as shown. Up to the age of 6 months, the child was normal, and after that, he developed alopecia, rash over the face, knee, elbow, and perineal region. There was history of fever on and off during the past. What is the diagnosis? So very nice everyone. This is a classical case of ectodermatitis enteropathica which occurs because of zinc deficiency. Now what happens? At the time of 6 months when the weaning has started, what happens? The mother milk is reduced and we have started giving the top feed. The top feeds are very poor in the zinc supplements, and that is why the patient have started developing zinc deficiency. And what is the classical triad of having the zinc deficiency? You can remember it with DDA, that is Delhi Developmental Association, or you can also remember it as DAD. So what are the features? It is the dermatitis, alopecia, and diarrhea. Dermatitis, alopecia, and diarrhea, that is called as DAD, or DDA, which is called as the Delhi Developmental Association. So any mnemonic you can remember. Now here there is a very characteristic property of dermatitis, and what is that? It occurs mainly around the orifices. For example, if you look here, you have presence of the disease around the oral cavity, as well as it is present around the genital regions. So what is it? Ectodermatitis enteropathica. It is nothing but it is a periorificial dermatitis, alopecia, and diarrhea. I hope this is clear. A 1-year-old boy was referred to skin department. Up to the age of 6 months, the child was normal. After that, he developed alopecia rash over the face, knee, elbow, and perineal region. There was history of fever on and off during the past year. What is the diagnosis? Option number 2 becomes the correct answer. Understood, Kennedy? It is not option number 1, it is option number 2. Coming to the next question. Requesting everyone to answer this. A very long question, and that is why I request everyone to read it carefully. What is the treatment, Kennedy, for ectodermatitis enteropathica? You have to give zinc supplements. And for the cutaneous lesions, if it is not improving exclusively on zinc, you can start with some of the emollients so that the eczematous lesions will be taken care of. Understood, Kennedy? But the treatment of choice is the zinc supplement. You have to give a proper nutrition. If you have started the patient on weaning, you have to give a proper balanced diet to the newborn. Okay. A term female neonate was delivered by lower section or lower section cesarean section to a primigravida mother with the parents being non-consanguineous. On examination, the vitals of the neonate was normal. A detailed physical examination showed broad, thick scales all over the body with prominence over the head, chest, abdomen as well as arm. On head and neck, there is presence of parchment-like membrane covering the head and the hair. There was associated ectropion and eclabion. The newborn has generalized erythema and edema. There is no associated abnormality. What is it? Now, if you look carefully, there is presence of if you look carefully, there is presence of what is called as a very thin shiny membrane which is called as colloidal membrane. There is presence of a very thin shiny membrane which is called as colloidal membrane. So can anybody tell me what is this? A term neonate was delivered by LSES to a primigravida mother with parents being non-consanguineous. On examination, the vitals of the neonate was normal. The detailed physical examination shows the broad thick. Anybody? Kennedy, Rahul? I want all the 5 students to please give me a thumbs up. Around 5 to 6 students, whoever is live. What is the answer? Colloidal membrane. I have given you a sufficient hint. Whenever you get colloidal membrane, please remember it is the lamellar ichthyosis. Now, all those students who are answering this NEET PG entrance examination, if you are not able to answer these questions, please join an academy for 1 month. It is very important because this is how you will get the questions now. You will have a long clinical case scenario based questions with multi-system involvement. Okay. Understood all of you? So what is lamellar ichthyosis? It is because of the transglutaminase deficiency. The child born with the colloidal membrane at the time of birth. And after that, they develop lamellar-like scales. In bullous ichthyosiform erythroderma, you will have bullous as well as erythroderma. In ichthyosis vulgaris, you will have fish-like scales all over the body except over the flexures. And in X-linked recessive ichthyosis, you will have black colored broad scales all over the body with associated cryptorchidism. If this is clear, I want a thumbs up from all of you. Please give me a thumbs up if you understood. A very important question and a new pattern question. Now let's do the next question. A child was born normally and was normal in all the respect till the age of 5 years. Thereafter, she developed roughness of the skin and pigmented spots. Such pigmented spots develop gradually all over the body. The child was born to a Muslim couple and her parents who are first cousins to each other. On examination, the child was thin-built, irritable, resented light. She was, however, intelligent, mentally mature of her age. All over the skin, hyperpigmented spots varying in the size, in diameter, and slightly raised above the surface were present. The spots have no definite shape. Some were oval while others were irregular. So, what is the diagnosis? Please answer this question. What is the diagnosis? Anyone can answer this question? Nobody's answer. I'm not able to see anyone's answer right now. So what is it? Acute intermittent porphyria, L-captonuria. What is this? Okay. So okay. So what is given in the question? The patient have given that the child was born normally. So there was no complication at the time of the birth. Okay. Now at the time of birth there is no complication and up till 5 years the child was absolutely normal. But the problem started after that. Please remember the problem started after that. The child was born to a Muslim couple. So it may be possible that there is a consanguineous marriage. And he or she tend to develop the lesions mainly over the photoexposed areas. Whenever a patient develops a lesion over the photoexposed areas and it is associated with development of the freckles, cutaneous malignancy, it is a classical case of xeroderma pigmentosa. And yes, you are right. Please remember in acute intermittent porphyria, you will not develop any of the cutaneous features. Very nice, Kennedy. So Kennedy, Chirag, you all are right for this question. Absolutely right. And I hope Rahul have also understood this question. Coming to the next question. Another very important question. A 24-year-old soldier presented with multiple painful erosions on dorsum of both the forearm of 3-week duration. The lesions were sudden in onset, recurring every few days, not associated with injury, insect bite or intake of the drug. Cutaneous examination revealed multiple linear erosions on the dorsal aspect of the forearm. The skin as between the lesions were normal. What is it? Anybody can answer this question. A very easy. Read the options, read the questions. Kennedy, Chirag, Rahul. 21-year-old soldier with multiple painful erosions. Now there is a history of recurrence. So this is the first clue. History of recurrence. Neither associated with injury, neither associated with insect bite or intake of drug. And the disease is present over the accessible site. Disease is present over the accessible site. What becomes the answer? Very nice. Everyone, please remember it becomes a case of dermatitis artifacta, which means that they have created the lesions artificially, and it is a sort of psychological disorders to gain the sympathy, to gain the attention. The patient tend to develop or patient tend to form the lesions over the accessible site. That is called as dermatitis artifacta. Very well done. Can anybody tell me what is dermatitis stimulata? Dermatitis stimulata. Anyone? What is dermatitis stimulata? Can anybody answer this question? Chirag, Kennedy, Rahul. How does it differs from dermatitis artifacta? What are the differentiating point? If you remember, I have told you this in my special classes also. What is dermatitis artifacta and how does, and remember, even though the pattern of NEET PG entrance examination have changed, nothing much have happened to the short subjects. You will get direct questions of short subjects now also. For example, psychiatry, dermatology, orthopedics and anesthesia, direct questions can come now also. So you need to know everything in detail related to short subjects. So anyone can tell me what is dermatitis stimulata? Please remember, dermatitis artifacta and dermatitis stimulata, both of them are same. Both of them are associated with psychological disorders, which is associated with attention seeking behavior or the behavioral disorders. But the issue is, in dermatitis artifacta, there is an actual lesion which is caused. They will actually injure the skin. But in dermatitis stimulata, they will not injure the skin. They will just put a paint and they will try to manipulate the area. They will try to, color the area so that it will look like a disease. So that is the very important difference between dermatitis artifacta, which is the actual damage, and dermatitis stimulata, where there is no actual damage. It is merely because of the paint. Okay, if this is clear, I want a thumbs up from all of you. If this is clear, please can you give me a thumbs up, everyone here in the class? Very nice. Another question on the computer screen. Let's do it. "18-year-old female presented with fever since 1 year, rash over face, forearm since 3 weeks. The patient was apparently alright prior to 1 month. Cutaneous examination reveals lesions over the face, forearm, chest and lip." So I can move a picture a little bit so that you'll have a better idea of this question. I want you to show the image. It is very important here. 18-year-old female with fever since 1 year, rash over the face, forearm. Please answer this question now. I think it is very much visible. So Chirag is in favor of option number 1. So Chirag, will you see erythema multiforme in SLE? What are these lesions? These are targetoid lesions. Remember, this is target lesions. You have a outer circle, you have a middle and you have a centermost circle. So this is a target lesions. So where will you see target lesions along with malar rash? Chirag, Kennedy, you both are right. Which is the disease where you have SLE plus erythema multiforme like features? The answer is Rowell syndrome. What is Rowell syndrome? It is a disease where you have SLE along with erythema multiforme. So it is, you are right, partially right that it is SLE, or Kennedy is also partially right that it is erythema multiforme. But if both of them come together, it forms Rowell's disease. Very important, it forms Rowell's disease. Can anybody tell me what is senior Usher syndrome? Anyone? What is senior Usher syndrome? Can anybody tell me this? Anyone? What is senior Usher syndrome? The patient was apparently alright prior to 1 month. Cutaneous examination reveals lesions over the face, forearm, chest and lips. Lesions over the face are in the form of palpable purpura, scars, targetoid lesions and the purpuric lesions. So this is a classical question of Rowell's, but the question is, what is the senior Usher syndrome? Please remember, senior Usher syndrome is pemphigus foliaceus plus pemphigus foliaceus with lupus vulgaris. Lupus erythematosus. So whenever you have features like the malar rash, or if you have features similar to that of erythema multiforme, this combination is called as senior Usher syndrome. If this is clear, please give me a thumbs up so that I can go to the next question, and all of you give me a thumbs up. Very well done. The next question is here on your computer screen. Please answer. A 7-year-old boy with recurrent respiratory infection was referred to our department because of unstable walking for 5 years and enlarged neck nodules for 2 months. Physical examination reveals anybody can answer the next question. So 7-year-old boy with a history of recurrent respiratory tract infections was referred to our department because of unstable walking for 5 years, enlarged lymph nodes for 2 months. Physical examination reveals scleral telangiectasia, cerebellar ataxia, and elevated alpha fetoprotein, which is very important. Elevated alpha fetoprotein. Can you answer this question now? Neurosyphilis, atypical meningitis, or ataxia telangiectasia? Anybody? Okay, so Amrit says it is option number 3, Kennedy with option number 4, and Chirag with option number 2. So please remember, whenever they say that the patient is having recurrent infection along with scleral telangiectasias and cerebellar ataxia, it becomes a classical case of ataxia telangiectasia. What is it? The first manifestation will be abnormal gait because of the cerebellar involvement. Because of cerebellar involvement, you have abnormal gait. The second feature is you have associated telangiectasias, whether it is in mucosa or it is in skin. And the third is you have increased risk of recurrent infection. Why you have recurrent infections in the patients of ataxia telangiectasia? Because of reduction in the immunoglobulin as well as T cell function. That is very important. So these are the features, and along with that, please remember that the alpha fetoprotein is also raised. Very important. The alpha fetoprotein is also raised in the patients of ataxia telangiectasia. Okay? So please give me a thumbs up if we are done with this question. Everyone give me a thumbs up if you are done. Any confusion? So what is ataxia telangiectasia? It is a nucleotide excision repair defect. I can write it with another pen. It is the nucleotide excision repair defect, which mainly presents with cerebellar involvement, telangiectasias, and recurrent infection. Very nice. Another question, please read it carefully and try to solve it, all of you. So what is it? When a patient of 11-year-old girl with a sixth, which is in 6th standard, the IQ is average. He presented with reddish brown hard bumps over the midface. She also had couple of small white spots over the trunk. There was neither history of seizures or visual defect or burning on exposure to sun. There is a plaque of 3 to 4 centimeter on the lumbosacral region. Mucous membrane of the oral cavity and nail was normal. Neurological examination was normal, and the ophthalmologic and slit lamp examination was normal. What is the diagnosis? Anyone can answer this. Von Reckling-Hussein disease, Bone-Villay disease, ataxia telangiectasia, or dyskeratosis congenita. Okay, so Amrit is in favor of option number 1. What about Chirag, Kennedy, Rahul? What about Chirag, Kennedy, and Rahul? Yes, so please remember, what are these small bump? This is adenoma sebaceum. This is adenoma sebaceum, not neurofibroma. Do you see any small white spot on trunk in adenoma sebaceum? Anyone? Sorry, in von Reckling-Hussein's disease. What are these white spot? The white spot are ash leaf macules. In von Reckling-Hussein disease or in neurofibroma, you will see hyperpigmented macules, not the hypopigmented macule. So everybody is wrong, Amrit as well as Chirag. It is not. The small bump are the adenoma sebaceum and the white lesion is the ash leaf spot. And what is this area? What is this plaque over the lumbosacral region? Anyone? This is the Sjagren patch. So this is a classical feature of tuberous sclerosis. This is a classical feature of tuberous sclerosis, a very classical feature of tuberous sclerosis. And in which condition you will see, or what is the another name for tuberous sclerosis? It is the Bonne-Villette disease. Please remember, you will get these type of questions in your exam. Try to remember them. Try to read them carefully, because see, the syllabus have not changed. Only the pattern might get changed. In the pattern, they will give you more clinical case scenario. They will give you the same thing but with a detailed history. So you have to pick the important words and then you have to solve this. I hope this is clear, Chirag and Amrit. And if you want these type of questions more in detail or in theory, please join Unacademy. Take a 1-month subscription. Use my referral code Cheshta10 or Dr. Cheshta YT. Dr. Cheshta YouTube. Okay, so Dr. Cheshta YT or Cheshta 10, please get yourself enrolled at least a month if you are sincerely planning for this upcoming NEET PG entrance examination. Everybody or all the educators, all the top educators are now taking the classes on the must know questions for NEET PG. Okay. Chalo, very nice. I think you understood. So what is Bonne-Villette disease? It is another name for tuberous sclerosis. Tuberous sclerosis will present with adenoma sebaceum, ash leaf spot, Sjagren patches, and you have something called as Conant's tumor also. Conant's tumor, which are the small tumors present over the nail bed. All these features will be seen in the patients of tuberous sclerosis. While von Reckling-Hussein's will present with the café au lait macules, it will present with neurofibroma, plexiform neurofibroma, iris leash nodules or axillary fractally. Okay? Another question given on your computer screen, please solve it. "62-year-old woman presented to emergency department with diffuse rash over her body following the second dose of TMP SMX, that is cotrimoxazole. The lesion started as a painful eruptions which progressed to blisters following diffuse exfoliation of the skin involving the bilateral lower limbs. What is the diagnosis? So Kennedy ash leaf macules are oval shaped hypopigmented lesions like this. So they will be oval shaped like this, hypopigmented lesions. That is why they are also called as lanceolate. You know how does lens look like? This is lens. So it gives you an appearance like a lens. You might be reading this in your ophthalmology classes. Please give me a thumbs up, Kennedy, if you understood this. Give me a thumbs up if you understood this. "62-year-old woman presented to emergency department with diffuse erythematous rash over her body following the second dose of oral cotrimoxazole prescribed for uncomplicated urinary tract infection. The lesion started as painful macules, progress into blisters, followed by diffuse exfoliation." Very nice, Amrit, very nice. This is a classical case of toxic epidermal necrolysis. Toxic epidermal necrolysis. Toxic epidermal necrolysis. Very important, try to remember this. Okay, so what happens in this? In toxic epidermal necrolysis, the patient will present with classical mucosal lesions You will have erosions over the mucosa. So you have mucosal erosions along with blistering of the skin or exfoliation of the skin of more than 30% of the body surface area. You have exfoliation of the skin of more than 30% body surface area, which is seen in the patients of toxic epidermal necrolysis. Now, how to differentiate it from Stevens-Johnson syndrome? Anybody can answer this question. How to differentiate this from Stevens-Johnson syndrome? In Stevens-Johnson syndrome, along with mucosal lesion, it is common. Mucosal lesion you will see in Stevens-Johnson also. Mucosal erosion in Stevens-Johnson, but the body surface area is less than 10%. But here the question says that, what does the question says? That the symptom develop within few hours. The symptom develops within few hours, as well as there is involvement of diffusion over the lower extremity, back, abdomen, which says that the involvement is more than 10% of the body surface area. Okay? So the correct answer becomes option number 1. What is staphylococcus? It occurs because of the staph infection, but please remember urinary tract infection is not because of staph, so it cannot be option number 2. It cannot be option number 2. In Rhetus disease, you should have a triad of conjunctivitis, arthritis and urethritis, so it cannot be Rhetus disease. And pemphigus will not occur secondary to the cotriamoxazole, so it cannot be pemphigus vulgaris. Very important question. I request everyone to please go through it. You can get many questions from this particular topic as well. Now there are many students who ask me that what is erythema multiforme? Can anybody tell me what is erythema multiforme? And how does erythema multiforme differs from the lesions of SJS? Anyone? Erythema multiforme and feature of SJS 10. Can you tell me how does they differ clinically depending upon the cutaneous lesions? Anyone can answer this? Please remember, in erythema multiforme, you will develop target lesions. So I will make it with the help of different colors. You will have a central like this. Then you will have edema like this. And the third is you will have erythema. So in erythema multiforme, you will have target lesions which have 3 zones. What are these 3 zones? The central is necrotic. Necrotic is central. The second is edema. Edema is middle. And the outer is erythema. Erythema is peripheral. So in erythema multiforme, you will have target lesions. But what about SJSN 10? You have targetoid lesion or atypical target lesion, which consists of 2 zones. And what are these 2 zones? Can anybody tell me which is the zone which is absent? Which is that zone which is absent in the patient of SJSN 10? So they have central zone of necrosis and they have a erythematous zone. There is no zone of erythema which is seen. So you have a necrotic center and you have peripheral erythema. If this is clear, I want a thumbs up from all my students. How to differentiate between the cutaneous lesions of erythema multiforme and SJS 10. Let's answer the next question given on the computer screen. 1-month-old female infant with uneventful birth was diagnosed to have a scalp swelling of 5-day duration. The baby was exclusively breastfed and gained adequate weight and was treated with oral antibiotics. On examination, a localized erythematous bogie tender swelling was noted on the vertex and there was exudation of pus. The hairs are loose and easily pluckable. Matting of the hair was also present. Nail and mucosa is normal. What is the diagnosis? Seborrheic dermatitis, Kirion, Favus or folliculitis. Can anybody answer this question? Very nice. I'm getting the answers. Mayank says it is option number 2. Kennedy says it is option number 1. And Chirag says it is option number 3. What about the other students? What about Amrit? Amrit, Rahul, what are your answers? Please remember, whenever you see a pre-pubertal child, whenever you see a patient who is before puberty, who presents to you before puberty, so pre-pubertal patient who presents with bogie swelling, over the scalp with loss of hair. This is a very classical feature of tinea capitis. Please remember, very classical feature of tinea capitis. And what type of tinea capitis is this? This is a classical feature of inflammatory type of tinea capitis, which is called as Kirion. Can you tell me what is the causative factors for Kirion? Anyone? Mrushka, Mayank, Chirag, Kennedy, Amrit, Rahul, anyone? What is the causative agent for Kirion? Anybody can answer this. I've told you a mnemonic. Kendra Vidya Mandir. So Kendra Vidya Mandir is a mnemonic to tell you what are the features of Kirion or what are the causative agent for Kirion. So I'll use a different color pen. K stands for Kirion, V stands for Trichophyton verrucosum and M stands for Trichophyton mentagrophyte. Okay, so it is Trichophyton verrucosum or Trichophyton mentagrophyte which is the causative agent for Kirions. So please give me a thumbs up. This is very important question. I've told you in the beginning of the session also that try to cover the infectious disorder chapter in detail, because you can get the questions from pediatrics in infectious disorder, medicine, PSM, microbiology as well as dermatology. So this is the common topic in all 4 or 5 of them. Another question, please answer this one. "19-year-old housewife presented within hours after her first delivery with fluid-filled lesion over the abdomen. On examination, multiple TENS, vesicles and bullae were present over the abdomen. Flexural aspect of forearm, thighs, back of the trunk, urticarial plaque were also seen. Nikolsky sign and bulla spread signs were negative. Mucosal lesions were present. Palm and sole appeared normal. Systemic examination was within normal limit and a baby was healthy, did not show any skin lesions. However, the birth weight was only 1.8 kgs, which could be attributed to any other causes diagnosis." Anyone? Anybody can answer this? Mayank, Kennedy, Chirag, Amrit. So they have given you a long clinical history. Anybody? A very easy question. What are the clues given? First of all, the patient have developed the lesions within the end of the pregnancy, that is immediately after the birth. The fluid filled lesions were TENS. Now if you remember, I have told you TENS means, whenever I give you TENS, it means that you have subepidermal bulla. Okay? You have subepidermal bulla. And if it is subepidermal, definitely the Nikolsky sign and the bular spread sign will both be negative. Okay, this both will become negative. Understood? So whenever you have the tense bulla, the Nikolsky and the bular spread will become negative. Now here they tells you that the mucosal lesions were absent and the systemic examinations were normal. So it cannot be syphilis, it cannot be Sheehan, and there is no history of drug given, so it cannot be drug rash. It is a direct case of pemphigoid gestationalis, which is seen very frequently in the second trimester, third trimester, or within few hours of delivery. Very important question. And can anybody tell me what is the basic defect? What antigen is affected here, or what is the antibody? Anyone? Whether it is IgG, IgA, IgM, IgE, IgD, anyone? And what is the antigen and what is the antibody? Can anybody answer this question? Please remember, here you have BP180 antigen which is affected, which is present in the lamina lucida, and you tend to develop IgG antibodies against the BP antigen or BP antigen 2. Okay? So please remember, this is a very important question. Please remember this. I hope it is clear. So the birth weight was only 1.8 kg, which could not be attributed to any other cause. So the answer is pemphigoid gestationalis. Yes, pemphigoid gestationalis can give rise to low birth weight. Even it can cause or it can give rise to development of vesicles and bullae in the newborns. But that is like for a short duration only. Another question on your computer screen. I hope you can see the clinical image. 29-year-old female patient with history of ulceration over the right lower leg since 6 months. The patient was referred from surgery department. Ulcers was refractory to the treatment. On detailed history, it was noted that the patient was a diagnosed case of ulcerative colitis. So this gives you a hint. Anyone? Kennedy, Mayank, Mrushka, Amrit, anybody? Anyone can answer this question, a very easy question. So anyone with the answers? I think now it is visible. Yes, very nice. Yes, the answer of this question is pyoderma gangrenosum, a 29-year-old female patient with a history of ulceration over the right lower limb. So there is a history of ulcer, and when you took the detailed history, she gives you a history of ulcerative colitis. Please remember, in the background of ulcerative colitis, if a patient develops ulcer which is not responding to either antibiotics or antiseptics, it means you are dealing with pyoderma gangrenosum. And what is pyoderma gangrenosum? What is it? Pyoderma gangrenosum is nothing but it is a neutrophilic. It is a neutrophilic dermatosis. What is it? It is a neutrophilic dermatosis, which is very important. Pyoderma gangrenosum, where you have collection of neutrophils, and this will give rise to development of sudden, very rapidly progressing painful ulcers, which will only respond to oral steroids and Dapsone. There is no role of antibiotic or antiseptics. They will respond to oral steroids or Dapsone. I hope this is clear to everyone. Very important question. Try to remember it, that pyoderma gangrenosum is a neutrophilic dermatosis. And what are the other neutrophilic dermatoses? Anybody? You have 4 types of neutrophilic dermatosis. Sweet syndrome, which presents with fever and erythematous nodules or plaque over the upper body. Second is pyoderma gangrenosum. Third is Behçet's disease. How does Behçet's disease present? It will present with oral genital aphthous ulcer, joint pain, eye involvement, as well as cutaneous features of erythema nodosum and furunculosis. And the last is NEH, which is called as neutrophilic eccrine hidradenitis. It is called as neutrophilic eccrine hidradenitis, a feature very very commonly seen in NEH or secondary to malignancies. So please remember, all of them are very very important. Now we have another question on the computer screen. I request everyone to please solve this. Moving the image a little bit over the left so that you have a better visualization of the image. Kennedy, Mayank, Marushka, Amrit, Rahul, I want everyone, Chirag, to answer these questions. And those who have joined new, please answer these questions. These are new pattern questions. You can expect this in your upcoming entrance examination. And if you feel that you are lacking, you're not able to answer this question, please join an academy at least for a month. You can have a practice session for this month because all the educators here are going on with their revision courses. Join my course using the referral code CHESTA10, or you can even use Dr. Cheshta YT as my referral code. Okay? So a 5-year-old boy presented with recurrent multiple itchy blisters all over the body since 2 months. What is it? There was no history of mucosal lesions, photosensitivity, trauma, consanguinity. General physical examination was normal, but on examination, there was multiple group vesicles, erosions present all over the body, particularly around the perioral, perineal as well as the lower trunk. Now, what are the hints which are given? The hint which is given here is that you have recurrent lesions, multiple lesions, and if you look at these lesions, there is a large central bulla surrounded by small vesicles. And what is this appearance called as? Anyone? This appearance is called as string of pearl or cluster of jewel. String of pearl or cluster of jewel appearance. Okay? It is called a string of pearl or cluster of jewel appearance. Very very important. Okay? Try to remember this. A 5-year-old boy with a recurrent history. This is also called as the chronic bullous dermatosis of childhood. So I assume that this question is clear to all of you. Please give me a thumbs up and let's move to the next question. This is the last question of the today's session. So I am requesting everyone to please answer this one. Please answer this question. Anyone? A 28-year-old female patient presented to our clinic with extensive erythematous lesion consisting of erythematous papules, nodules. Shraddha, Mayank, Mrushka, Gaurav, Pooja. So many of the students have joined late. Gaurav, welcome to the class. Pooja, welcome to the session. So few names which are familiar. So what is that? Whenever you see a patient who present, one second, there's some issue with the connection. Whenever a patient presents to you with erythematous papules, nodules, with associated ocular involvement, please remember, whenever you see a patient with erythematous papule nodules, which is associated with burning on exposure to the sun or flushing on exposure to emotional stress, whenever these lesions are associated with ocular lesion, it becomes a classical case of rosacea. Because you should know that rosacea have 4 forms. First one is called as, there are 4 forms of rosacea. The first one is called as the erythemotelangiectatic. The first one is erythemotelangiectatic. Second is papulopustular. Erythemotelangiectatic, papulopustular. Then you have phimosis, or which is called as the rhinophyma. The thickening of the nose, potato nose, and the last is the ocular rosacea. So please remember, there are total 4 types: erythemotelangiectatic, papulopustular, phimosis, or ocular rosacea. Very very important. So I hope you have enjoyed the today's session. This was a 1 hour short and sweet session where I have discussed many of the new pattern questions which you might expect in your upcoming entrance examination. Now I want all of you to please give me a thumbs up if you like my class. I want you to give me or write the comments over the chat section also. Don't forget to press the bell icon for the notification of my further classes, and please take a subscription of 1 month so that you can have an access to all my classes. So bye bye everyone, take care, and we'll meet again soon